Hello, everyone. Welcome to it's Ask the Experts, but today's kind of like a lunch and learn because we have a special guest. So first of all, thank you so much for joining the IOCDF's live stream. So the IOCDF live streams, what we're basically doing here today is we're just trying to offer you resources. The IOCDF is your go-to. I always think of it as like the American Heart Foundation or Society for OCD. So they provide resources, education, scholarships, all this different kind of amazing stuff to help people with OCD and related disorders. And one of the things that we want to do with these live streams is provide education and community and resources. So myself and Liz host these. And before we jump into our special guest, we haven't introduced ourselves in a while. Do you want to do that first, Liz? Because I feel like some people come every week and they know us, but some people are newer. So do you want to introduce yourself?
Let's do it. Yeah. So, and then Fred, we'd love for you to introduce yourself as well. We're so excited to have you. And I actually have lots of live questions that I'm excited to ask you about just how to navigate insurance and how to make sure people can get access to treatment. So I'm really excited for today's talk because I think it's a really important one and it strongly aligns both with all of our mission and background and what we do and how we serve patients, but certainly with the foundation. So thank you for being here. My name is Liz Mackingville. I am a national advocate for the foundation. I've been an advocate and a spokesperson in the OCD world for a long time. I'm also somebody who lives with OCD and treats the OCDI in Houston, where we have a residential and PHP program. So I do active clinical work every day, but I always say that my advocacy hat tends to trump everything else that I do because it's what I seem to do day and night. So it's what I love and it's really what builds me up. And I'm just honored to be here and to be a part of the foundation.
Thanks, Liz. And my name is Chris Tronson. I am one of the IOCDF's lead advocates. I also head some of their special interest groups, and I'm on the board of the International OCD Foundation, as well as vice president of OCD Southern California. And like Liz, I have OCD, and as an advocate, really just want to give resources and education and make people not feel alone. And then as a clinician, I've come full circle. So I'm a licensed therapist here in Orange County, California, where I treat OCD, body dysmorphic disorder, and related disorders at a private group practice called the Gateway Institute, and have been enjoying hosting these live streams. But today is a very special guest. I don't think he probably even remembers, but when my mom and I were the keynotes at the IOCDF conference, I think you were getting an award. So you were on the stage with us for a while, Fred. I don't know if you remember, but you're somebody who my mom provided me with articles and things like that when I was going through treatment. So it was an honor to be on the same stage as you, but it's an honor to have you today. So Fred, can you introduce yourself to our viewers?
Okay, I'm a licensed psychologist. I'm the executive director of a treatment group here in Huntington, Long Island, New York. I have been treating OCD. I'm the executive director. I think I might have mentioned that. I've been treating OCD now for I'm in my 41st year treating OCD, probably treated, I guess by my own reckoning, probably over 2,000 people by now. And I've made it kind of my mission in life for there to be less OCD in the world. So this is what I've dedicated myself to. I've helped train some of my associates. My wife also works together with me and also specializes in OCD, and we've worked together for quite a few years. So it's kind of a family mission, you might say, to work with people with OCD. I'm also a member of the Science Advisory Board of the foundation and was a founding member of the Science and Clinical Advisory Board, actually, since about 1990, if I remember correctly, and have been to, I think, about 26 conferences also over the years. So we go back a long way, the foundation, and I lectured for them when they were very, very small back in the early 90s and all. So I've been doing a lot of things on and off over the years. So I'm happy to do this too, because anything I can do to further the mission here, I'll be happy to do.
Yeah, so real quick before we start, I forgot to make a quick announcement. Always remember that if you don't have a clinician, you can go to iocdf.org/find-help for the IOCDF's online resource directory. Don't forget that if you're feeling suicidal or unsafe, we're only a live stream. We can't support you in that capacity. So make sure to dial 988 or go to 988lifeline.org. And then we want to have a safe and kind and respectful space. So make sure that You're being here to support each other, and this is being broadcast so that people can watch this afterwards. So Fred, obviously, you've been doing so much for the community, super impressive. Well, the way we're going to kind of run it today, I see we already have like live questions that are general OCD that we'd love to answer. But before we get into that, one of the reasons that we brought you on is because I know that you have done presentations, and by treating OCD for a while, help people navigate to get treatment, whether it's resources, clinical trials, insurance. So a lot of people, one of the things that Liz and I get a lot on these live streams is that they can't find or afford treatment. What are some first steps that you could help people with so that they could navigate some resources for OCD treatment, evidence-based?
Okay. Well, where I would start would be in addressing people who have insurance, first of all, have some kind of health coverage. Now, in most insurance plans, they will refer you to people who they say are specialized in treating OCD. Unfortunately, in practice, this doesn't usually turn out to be terribly successful. A lot of the people who are on the panels of the insurance companies aren't specialized. And in fact, due to insurance company policies, specialists dropped out, a good deal of them, quite a long time ago. Actually, at one time, I was on the panel of just about every insurance company that you could be a member of. And now I'm not on the panel of any of them, unfortunately, due to insurance company policies. And in some ways, regarding insurance, things have gotten better over the years, and they've also gotten worse. What's gotten better is that federal law did away with like lifetime caps on the amount of money that an insurance company could provide for someone's treatment, or the number of sessions a person could have yearly or lifetime. So they struck that down, and now this is why federal law requires that psychiatric problems be treated to the same level that medical problems are treated. It used to be quite different. There used to be very strict limits on psychiatric treatment that you could get for literally anything, basically. So that way things have improved. But the way that things have not improved is that over the years, the insurance companies discovered that if they lowered their fees, that they could attract people who would accept lower fees to work for them, and that all the specialists who were generally more highly paid because of their experience ended up dropping out. So a lot of the people who ended up working for the insurance companies were not, top flight people or what I would call real experts. Basically, they left the insurance companies, it's an unfortunate reality, but it is true. So anyway, getting back to the insurance company, and by the way, just as a disclaimer, I'm not terribly fond of the way insurance companies run themselves these days relative to mental health, just so you know. And it's not because I have any inherent prejudice. It's because of my own experiences in trying to work with them over the years. The paperwork has gotten excruciating with them. They oversee cases and will actually kind of look over clinicians' shoulders and tell them, what they should be doing and how they should be doing it and how many sessions it should take them to do it, regardless of the realities of the case. And the people who do the supervision for these companies are people who really don't know anything about OCD. They're often like a panel of like nurse practitioners or other people with that level of training who really, if you really ask them if they understand OCD, they really don't, basically. But they usually sit there and read from scripts when you talk to them that are sort of pre-written for them, and they generally don't deviate from them. But anyway, getting back to how to get your insurance company to pay. First of all, insurance companies are obligated to give you treatment. That is the law, and they must do that. They must provide you with effective treatment also. However, they don't always do this. So generally, they'll give you a list of people to call, and a lot of people's experiences, they'll run through everybody on the list, and either the people will say, "I'm not taking new patients," or I don't know why I got on the list. I don't really treat OCD. Or they'll say that they do treat OCD, and then when you question them a little further, you find out that the methods that they're using are not accepted approaches, that these people really don't have the training or the experience in treating OCD. So this, unfortunately, is all too common an experience that people have. So in fact, I'll give you a good example just from a case I've been recently working on. Obviously, I'm not going to name names or identify people in any way, but I will say this person was an adolescent, and parents tried to get the treatment for this adolescent, and they went through every name on the insurance company's list, couldn't find anybody. So they finally decided to go outside of the insurance company. So they called me, basically, and I agreed to take this adolescent on as patient. And one of the things they asked me, they said, well, is there any way you can work with our insurance company? So I said, well, first thing you have to do is call them and find out, do they do what we call out-of-network contracts? Because if they cannot provide help within the network, the law says they have to allow you to go outside the network for treatment if they absolutely cannot provide treatment, because under the terms of your contract, they have to provide treatment. Now, there's one exception to that, is that some contracts are negotiated by employers that strictly rule out using outside people. So if you have one of those contracts, then legally there's not much you can do. There's very little recourse you have, because this has been something that's been legally agreed to, and then the insurance company isn't required to do that. But that's not all that common, actually. So anyway, these people called their insurance company. They found out that yes, the company does do out-of-network contracts, and so it was up to me then to call the company and give them my particulars, like my license number and all my relevant numbers and other things to prove that I was who I said I was. And they then said, okay, we'll take it under consideration. So they went back and they made us wait several weeks, which they usually do. And then what happened was they did get back and said, okay, we're going to approve 25 visits provisionally. And see, and actually they were in this case, they were actually pretty good. They actually backdated to the first time I saw this person. The parents said, look, start seeing him, even if the insurance company won't pay, we'll pay out of pocket. We don't care anymore. We just got to get our child better. So in any case, I they agreed to let me be an out-of-network provider. The only catch, and there's one holdup at the moment, when I was on the phone and I was just speaking to someone at this company yesterday, I said, okay, very well, I'm accepted. I said, but what are you allowing to pay for each one of this kid's sessions, basically? And they said, well, we can't tell you that. I said, well, what do you mean you can't tell me that? I said, when I submit a claim and you send payment, I'm going to find out anyway, right? So why is this such a secret? They said, well, we're not allowed to give out that kind of information. And I said, well, you have the code, the treatment code, and you have the diagnosis code. I said, what's preventing you from giving me that information, since I'm going to find out anyway? They said, well, sorry, we still can't tell you. They said, you'll have to submit a claim and then you'll find out what we're going to pay. So this is not untypical. This is the kind of hoops they make you jump through, basically. So at the moment, I'm in, but if I find out that they originally said that, oh yeah, we'll pay whatever you submit. They said that, but one thing I've learned with insurance companies, until I actually see it in writing, I don't believe it. I've even had them approve of sessions for people, then turn around and say, we never approved that. Except in one case I'm thinking of in particular, we had the paper in hand and said, well, we do have it in writing, so you have no choice. And they said, well, we still didn't approve it. So your next recourse, by the way, if your company gets kind of funny with you on that, most states have a bureau that regulates in practices of insurance companies in that state, basically. Like in New York, where I am, we have a state commissioner for insurance. And if you have a complaint about an insurance company, you go to this commissioner's office to get it adjudicated. Now, this company has great power and decides who gets to sell insurance plans in New York and who doesn't. So the companies fear this office, basically. So if you have a complaint, I tell people, go to this office, file a complaint, and let's see what happened. In the case I was just referring to, they said to the company, sorry, you agreed to it, you have to pay, you don't have any recourse, too bad, you may not like it, but that's our ruling, and you can't appeal it, that's it. So in that case, we have very good oversight here in New York State, which is good. I don't know what the laws are in other states, but there's usually some office that regulates insurance and that you can file complaints with. Now, relative to filing complaints or any other dealings you have with your insurance company, one thing that I also strongly recommend is that whenever you call your insurance company, first of all, get the name of whoever you're talking to and make sure you get the spelling correct. Number two is they usually, for every call that you make to an insurance company, they have on file like what they call an incident report, which means basically they assign a number, a case number to the call that you made and other, information about the call. So get that number also, because then you can refer to that. Because a lot of times, if you don't have that, they can say, "Well, we never said that," or "We never got that call," or so forth. So they they can do that. So that's one thing that they unfortunately, they're pretty tricky. And the first people you talk to are just people who are mostly reading from scripts. They're not in a position of power to make any decisions about anything. So if you really want to find out about getting things changed or making decisions, you have to move up a level. You'll ask to speak to a supervisor. For say, well, who's your boss? Let me speak to them, and usually they will put you through. But if the person's giving you a hard time or is not being cooperative or even being disrespectful in some way, which usually doesn't happen, but once in a while you get people who are maybe they're having a bad day or something. But if you get their name at the beginning of the call, I advise people to do this. I say, call the state commissioner's office, or say actually, I'm going to call the state commissioner's office and I'm going to give them your name when I call. And that immediately clears out a lot of things, because now they're being held personally responsible for their own behavior. Usually when you speak to someone and you don't know who they are and you never get that information, they remain anonymous and you have no recourse, because you can't claim anything or refer to anything specific. But you want to get all the information you can. You should write down, what you talked about in your call, who you spoke to, and again, the incident number for that call. So that's your protection, basically. And also, any papers they send you, don't just tear them up and throw them in the trash. Save them, make a file or something, put them aside. You want to document everything that you get from them.
So I really appreciate the overview, Dr. Penzel, and I think it's really helpful. And one of the things I want to say is I like, as you're talking through all this, I totally resonate, because this is what we do, right? So a lot of our clinics that are self-pay clinics, we navigate the process with our patients. And so what that means is that while my clinic, for example, in Houston, it might be self-pay, a lot of people think, oh, that means I have to pay 100% cash and I'm never going to get reimbursed. And that's absolutely not the case. Some of our latest numbers showed that like 82% of our patients here use insurance. We help them navigate the process. What that means, you guys, is that we are in-house. What happens? So, for example, the day someone admits to our program, it's a little bit different because we're talking residential and PHP than outpatient. The day they admit, we ask them to arrive and to bring their summary, their benefit summary. This is really important. So one of the things you want to do is call your insurance company, number one, and ask for a benefit summary. They'll either send you it or tell you how to go online and download it. But this is important because it allows you to know, based on your plan, what is your current benefit summary. So do you have accessibility to out-of-network help if help is not available in network, right? And can you file for single case agreements, for in-network exemptions? You want to know all those details. And so what we always will tell people is, please bring that with you so we can review it with you together and help decide what we're going to go for. So for our patients, we typically always are going to go for an in-network exemption. For some of our patients, we're going to go for a single case agreement. A single case or special case agreement is where providers or clinics, we work directly with the insurance company and they actually would pay us directly. So Kaiser, for example, I know, Chris, you guys use Kaiser at Gateway, right? Kaiser is an insurance company that seems to have really good mental health benefits. Kaiser, we will find, will cover an SCA with us often. We've had patients who use Kaiser, and basically we then are navigating with Kaiser. They're paying us directly. The patient never pays out of pocket. A lot of our patients, that's very confusing to them. They're like, well, Liz, I thought you're self-pay. Why are you using insurance? And it's like, okay, we are not, as Dr. Penzel said, we are not credentialed or in network with any insurance providers, right? Just as he is not. But that doesn't mean we don't help our patients be able to use their insurance for payment. And we would, in fact, encourage all of our patients to do so. And so it's really about working with yourself and your provider to say, okay, what are my options to help get reimbursement, and what does that look like? Sometimes for outpatient providers, they will say something like, we'll give you a super bill and it's up to you to file independently. Some outpatient providers will work with you. And then clinics, if we're not in network, we should be working with you. So what happens is when a patient comes, we then will help them file for what's called an in-network exemption. And so within the first 48 hours of admission, our clinic, right, the clinicians, we're calling in not one of my clinicians, someone else is calling in for what we call a pre-authorization. And when we call in a pre-authorization, what we're saying is, let's say Chris admitted to my clinic. I'm saying, hey, we have a patient of yours. Here's their date of birth and here's their policy number. They have now admitted to our clinic. And so we're calling in for a pre-authorization for this level of care. And we're going to say, oh, Chris is going for residential or PHP, right? We're going to talk about the level of care. They're then going to confirm we meet their requirements, because each insurance has different requirements for levels of care. And then they will assign a case manager. That case manager will then be working directly with your behavioral therapist, so whoever Chris is assigned to be giving authorization and approval. So like for us, they might say, okay, we're approving Chris for 10 days of residential. We will give you a call back in 9 days to work on the next 10 days and make a decision if we'll continue to get approval. And so that is really confusing actually to a lot of patients, because they're like, wait a second, so you are doing it in-house? What's happening? We are absolutely working with insurance, but we're not credentialed with insurance. And, you know, I say this because Dr. Penzel, one of the things I want to talk for a second about is how bad insurance rates have gotten. We don't have to get into that of like this being, but I think sometimes there's this bad rap of clinics that aren't in network of, it's like, oh, you don't want to be, or you don't want to serve individuals. And it's like, whoa, I would love to be. And I want to just put a PSA out there that I'm trying every day to get in network with anyone who will meet our rates or come close, so that we can keep our doors open and offer quality care. So if you have an in, please let me know so that I can navigate that, right? Because all of us would want so bad to be able to be in network and serve our patients, right? Nobody wants people to have to pay out of pocket or for access to care to potentially be tainted by finances. And so I think that's really important to state. And I don't want anyone to think, oh, if it's a self-pay clinic, that means I can't use my insurance. You can. It just often means that you may have to do a little bit more of the work on your own, and you have to navigate and learn a lot of that back end stuff.
Sometimes your out-of-network person won't have to be credentialed by the company. They can just provide you with a paid receipt, and then the person submits that to their insurance company, and they get whatever reimbursement they're going to get under their plan. It may not be at the same rate as from an in-network provider, but some people have arrangements like that also, where they can just submit a paid receipt to their company and get as long as it has all the required information on it, and can get paid back that way. Some companies it's different. Sometimes they'll pay the patient, and then the patient's required to pay the provider. Sometimes they pay the provider, and then that's where it ends. The person doesn't have to pay anything out of pocket, as Liz said. Sometimes, let me see if I can get this straight. See, the thing is too, over the years, they have I think as I mentioned, the company lowered actually the amount that they would reimburse, even though costs and fees have gone up for clinics. So what happens though is that if a provider agrees to accept a lower fee in a particular person's case, like even if they really want to help that person out, the problem is that from then on, they have to agree to accept that fee for all patients coming through that company. They can't get different rates of reimbursement for different patients under the same plan. You have to just accept, then you don't have no choice from then on. So that's a way that they kind of tie people's hands, by the way.
Yeah, can you talk a little bit about, I know for some of my clients that we were in network with Kaiser, obviously for our IOP, for outpatient sessions, some clients, their insurance, we use Simple Practice. So Simple Practice kind of comes up with all the codes, and then the clients are having success. They're, reimbursing, or they're sending the super bill to their insurance companies. Some insurance companies are much more modern with it. It's like they scan it, it uploads, and then direct deposits like 5 to 7 days later. And they're getting, some of my clients are getting 80 to 85% reimbursement rate. So what we do is we have a client find out their out-of-network benefits. We'll give them like a super bill with the codes just so they can see what it is. And then typically it's a pretty easy process. I just think that I know for one of my doctors, for my allergy doctor, he doesn't take my insurance, but I have a PPO, and he's able to do the same process I do with clients. And so I just submit it to my insurance and usually get a check, direct deposit. It sounds overwhelming and scary, I think, to some, but would you say the process is a little bit manageable, or how do you feel about that, Fred? Dr. Penzel.
You have to be organized, basically, if you're going to really be successful with insurance companies. Like I said, save everything. You can often get help with those things too. They actually, if you call your patient hotline, usually at your company, and you're having problems with that, I will say they will sometimes provide someone who will help you kind of work your way through these things, because they don't want to make more work for themselves either. I have discovered a couple of interesting quirks about insurance companies over the years. I've had patients who actually work for some of the insurance companies, so I'm able to get some inside information that you don't usually get. Insurance companies don't like to pay right away. So what they do is they delay. And actually, I know this because my wife used to be in investment banking and actually worked investing money for big insurance companies. But what the insurance companies do with the money that they're not paying out to you, if they can delay it, they take this money and they invest it in overnight short-term currency trades and make a lot of money on the currency market. So this is a common practice. Another thing that I found out that they do through this patient of mine actually worked for an insurance company, one of the big insurance companies. He said when they got too backed up with claim forms to process. Now this was a while ago. Maybe they've gotten more efficient since then. He said when they get too backed up and they started dealing like stacks of claims that people would send in, they would just walk over and throw them in the shredder, basically. And then if you said, well, where's my claim? They said, well, we never got it. And of course, since it was now confetti, nobody could prove that they never got your claim form. Third thing that I would share with you is it's just a little tip on sending in claims. Do not send in too many all at the same time. If you like send in like 6 months worth of claims at once, they will find an excuse again to not pay right away. They'll say, well, there's missing information. And I just had this happen actually last week. The company said, well, there's missing information. So we said, well, what information is missing? And they said one of the codes was on. We said, well, it's pre-printed on the receipt. How can you say that? Obviously, you're not reading it because it's right there in black and white, and the forms actually are black and white. So we said, how could you? And they said, we must have been an oversight. We'll correct that and all. But this is after delaying things for weeks, and then sending out letters and going back and forth. I mean, this is unfortunately what happened. But they make money off the money they're not paying out, and again, nobody wants you to know this, but it's actually what does happen. So if they can delay you several weeks, that's money that they get to invest in other things and make more money with.
Oh, that frustrates me. It's so frustrating because obviously people are paying their monthly dues for an insurance company. I spend $550 for insurance for myself, which is just ridiculous. And I went to the doctors once last year. So it just is so maddening that so many people are putting out so much money to their insurance companies. And then when they try to get reimbursed for anything, the whole reason they have insurance in the first place, you almost need like a separate degree to be able to navigate. It's extremely frustrating.
It's true. It can be very frustrating process. But again, remember, these companies are not in the business of social welfare and reform. They are in the business of making money for shareholders, basically. So this is why you see them operating the way they operate, and gradually there's more and more laws, but they have acted with a lot of impunity over the years. When I first started treating people with OCD, there were some people who were like limited to like 20 sessions a year for a particular diagnosis, or sometimes they had like lifetime caps. So they'd say to a person, this person, like especially somebody with really serious symptoms who needed a lot of intensive work, they say, well, sorry, you've exhausted your lifetime cap. We're not paying any further. And legally, they could get away with that. And meantime, the person would say, well, I've got these other health conditions. You've been paying for years for unlimited treatment for that. They say, well, yeah, but that's in a different category. That's mental health. That's not medical, physical medical problems. So, but as I say, that's improved somewhat.
What about, I know sometimes people will ask about Medicare, Medi-Cal, things like that. I mean, is there options for individuals with that type of kind of like Medicare, Medi-Cal? I think Medi-Cal is only California, but I'm not sure if there's like a version of that for every state. But what about people that are navigating with that?
Well, I'm actually old enough to qualify for Medicare myself. I have Medicare, so I can speak about that personally. If you have a good supplementary plan along with your Medicare and a good drug plan, for instance, it's really quite easy to work with, and my doctors really have no problem with Medicare. I've never had any problems collecting for any reason for that. I actually used to be a Medicare provider, but it was kind of an interesting story how I got to not be a Medicare provider, which was one day they somehow messed up my mailing address. So I didn't hear anything from them for like several, like many months. And then it started going into years. And I said, what's going on here? What? So I contacted them and they said, oh, well, you never responded to the things we sent you by mail. So we disenrolled you. I said, but you sent it to the wrong address. they said, how could I be responsible for responding to things that I never received because of your clerical error? So they said, well, sorry, we're not responsible for that. But if you want to reapply, they said you can fill out this form, and it's online. So I looked up the form. It was about 35 pages long. And I said, there's no way. It would take me like probably a good week to fill this out. And then I have to get all kinds of other documentation. So I said, forget it. I'm just, I just let it ride basically as it was. It was unfortunate. I didn't want to do that. But, and in fact, what I did was the patients that I was seeing on Medicare, I just dropped their fees like substantially just to, so they wouldn't have to be penalized because of Medicare's errors basically and be forced to drop out of treatment.
What about for people if they don't? I know you gave some great advice for people with insurance. What about people that don't have insurance, or their insurance is an HMO and isn't going to reimburse them, or if they're having any troubles like that? Is there other options that people have?
One option that I was just telling people about recently was the idea that let's say you find a local therapist, somebody you can afford. Basically, but obviously not covered by anything, and you don't have any coverage either. One way is to, if you can get them to get supervision from a more experienced clinician who will, meet with them periodically to supervise your case and advise them on how to treat you, then you're sort of getting more expert treatment indirectly, which is one good solution. And I often recommend that to people, especially if they live in remote areas where there's very little in the way of resources. As far as a lot of states now also have plans for children. Also, even if they don't have them for adults, I know in New York we have special plans for children of people who don't have insurance coverage. So that's another option. Sometimes there are foundations or organizations that will also help defray the cost of treatment. But again, I can't think of any off the top of my head, but you can certainly research that. I'm sure there may be some, but it's not an easy thing. I mean, luckily the federal government has made in many states, it made it easier to get a coverage under government sponsored plans and all. Some states unfortunately still don't adhere to this, so you can't get that in those states, but more millions of people have been enrolled and now have healthcare coverage than did several years ago. I think it was under President Obama that they extended that. They called it Obamacare, but that's extended coverage to a lot of people. So that's also being remedied. But again, there's still millions of people out there who don't have coverage. It's not an easy thing to do. I know there are also government programs that cover hospital bills for people who are indigent or who can't afford to pay or fall below the poverty line and all. I think there was something called the Hill-Burton Act years ago when I did inpatient work in hospitals that covered some people's treatment who couldn't afford it themselves.
Yeah, I know that Dr. Jenny Yip, who's on the board of the IOCDF, I know her clinic, Renewed Freedom Center, for instance, has associates that she supervises that can work on a really big sliding scale. I know that obviously it's there's not plenty, but sometimes there'll be clinical trials where it's like they're looking for individuals to get about 3 months worth of sessions for OCD treatment. So there are some things that people can navigate in that space as well.
I also, another thing which I slipped my mind for a moment, which I just remembered, is that if there's any universities in your vicinity that have clinical psychology training programs, they almost invariably, I don't know one that doesn't, they have their own outpatient clinics where they offer services that students conduct the therapy and are supervised by faculty members, senior faculty members. And the fees are usually little to nothing, basically. Long Island University, which is not far from where I am, has an outpatient clinic where I think they collect like $5 a session. And you can work with a student who's working on their doctoral degree, but at the same time their casework is being supervised on a weekly basis by a faculty member who is licensed and experienced. So this is another way to get good low cost treatment that is available wherever there is a university with one of these programs.
Yeah, I know that Barbara Van Noppen, who's part of the scientific advisory committee, USC and through Keck Medical School, they're linked up with LAC, which is like a LA hospital, and they are able to provide ERP and support groups. I know a clinic like mine has low fee support groups for people that come, and even though it may not be the same as one-on-one, but they're still getting like a clinician licensed therapist running a support group. A real quick question about insurance. Do you recommend an HMO or a PPO? Does that seem to matter that much in reimbursement? What are you kind of recognizing?
There's so much difference between plans and even plans within one company's offerings. It's hard to say exactly because the rates vary by location. They vary by the state, the town, the fees, what they call their usual and customary fees, UCFs for short. They can vary widely even within one state. So I'm not sure I could really answer that adequately because it could, I could give you something that might be, it might be accurate for here where I'm located, but maybe over the next state, it might be completely different. So I don't know. I mean, usually if you belong to any kind of plan where you're limited to going to their providers, it's going to be much less likely that you're going to find a specialist because what they pay their providers generally for in-network people is fairly low and does not attract experienced and specialized people as a rule, but
so I for some reason feel like we have heard PPO has a much better chance of getting like out of network exemptions and things like that. I think the two big pieces, because I don't want to see it too far into the details and gritty because I think it really depends on each person's insurance plan. I think one thing, Fred, I don't know if I can put you on the spot, but you wrote an article about how to kind of navigate getting insurance reimbursement a long time ago for the foundation that we use. And it may be wonderful for us to update that. Like maybe we could even update it based on like level of care you're looking for and what are like, I could help share what we've learned and like what it looks like for us and
sure.
And we could put that together because the big piece, you guys, is that you have to be your own advocate. And what you are advocating is that I have a disorder that requires specialty evidence-based care for my disorder. And I cannot find somebody within your network that engages in the treatment that I need to get better. Therefore, I am required to get out of network help. And so again, remember, if there is someone in network who does ERP that's available, you're going to get pushed to go do treatment with them. And that does make sense. But what you're saying is that the specialty care I need is not available in network, or there's a really long wait, or I can't get in right now and I need that treatment, right? So you are building a case that this is the only option for you to get the correct help and the help that they should be giving and offering to you. And so those are really important things to keep in mind. The second piece is that each one of your plan is different and each one of your carriers is different. So their willingness, their rules, right? Again, I can have a residential program in Texas. Texas is a weird state that doesn't have a license for residential unless it's substance use. And so we meet criteria for most providers, but some insurers will say, oh, you don't meet our criteria, right? And again, that's something we then have to navigate and say, okay, well, is PHP available for this patient? And what would that look like? We are often, when we get a no, we're going to an appeal. We're asking for an appeal. But, an appeal is something I'm asking the patient, hey, do you want me to appeal this? Because I want you to keep in mind, you often only get 3 appeals like within a year. We need to ask their company. And so is this something you want us to use one of those for? So anyway, my point is that I think this is a really great conversation. And what I want you to hear us saying is that you have to advocate, you have to figure out your personal plan and how to fight for it. And just because you hear somebody say, oh, I'm not in network or we're a self-pay clinic does not mean you can't use your insurance. And it doesn't mean you can't get reimbursement. The process is just a little bit more wonky or difficult to navigate. The last piece that Chris said I want to touch on is that one of the things I always tell people, if you don't have insurance or you can't afford to pay the difference, if they're not going to cover the full cost, look to see if there's any OCD clinics that do training in your area, because most of us that are training clinics, so we have postdocs, we have practicum students, we have social work interns, we can offer sliding scale. And so I can see somebody for as little as $10 who's getting amazing evidence-based treatment supervised by a spectacular clinician that is going to be so much more valuable than you going to somebody else who doesn't do ERP. Not to say there's not other people who don't do ERP, but I always say that look for institutions, look for clinics, look for bigger group practices that have student options, because that allows sliding scale.
Yeah, I totally agree with what you're saying. And I was just mentioning before about university centers also. Doctoral programs have usually low fee clinics where you can get student psychologists, for instance, who are being supervised by more senior faculty. One thing I was going to add was that I think, as with purchasing anything, that I think you have to be a smart consumer, basically. And being a smart consumer means knowing your rights and all. And I think it's always important to find that out, as you were saying, that, you have to, you are responsible for giving me scientifically based informed treatment that is shown to be effective. And you can insist on that. And they really have to do that, just as they would with any kind of treatment, basically. But again, they don't make it easy for you, because, for instance, they're going to have a list of maybe 20 people who they say are qualified, and you'll have to indicate to them that you called every person on that list and either couldn't be seen by them, or that person didn't do the treatment, or whatever other reason, before they will let you go out of network. So you can't just automatically say, hey, I want to go out of network because I found somebody who's really good. They say, well, you haven't exhausted our resources yet, so sorry. That's the rules. And you may have to play by their rules to a degree. And another thing I would also add is, always, whenever you call your company and are dealing with them, be polite, be courteous, don't lose your cool, don't call them names, don't shout at them over the phone, because what happens, you'll be labeled in their files as a troublemaker, basically, and they will not be as nice and as giving to you, or tell you things that you need to know. So you want to always have good relationship with the company, even if they're in the wrong, even if they're not doing things that they're supposed to do. You're getting hot under the collar at them will not improve your situation any. And we know that it can be very frustrating dealing with them. I deal with the same frustrations myself on a regular basis. But again, I think if you talk to them nicely and politely, you're more likely to get what you want from them than if you start out in an adversarial way with them.
Really good advice. Felice put in the comments that she talked to her insurance company, got some of the people off of the panels that were like saying OCD, but when she called, they were like, nope, we don't do OCD. So sometimes it's like us in the community advocating. I want to switch gears a little bit, Fred, because we have a bunch of questions that we're going to try to get through as many as we can. So we'll start with the first question. Solil at 8:18 my time, your time, Amanda, that's 12:18. Do you all notice that your clients typically suffer from headaches daily because of OCD, and is there any advice? So are you noticing that individuals with OCD might complain that they have headaches maybe more often than the average person because of OCD?
Are you talking to me now? Or?
Yeah, I'm throwing it out there to the whole group.
Okay.
We'll let you start, Fred.
Oh, okay. Thanks. I don't mean to jump in, but okay. I would say, based on my own experience, it's not all that common. Occasionally, I'll find someone who, due to stress or tension relating to their symptoms, may experience headaches, just like people can get tension problems in other parts of their body when they get anxious. The other thing you might want to look at if you're getting regular headaches is you might want to also check if you're on medication to see if that's potentially a side effect of something you may be taking, because that might also occur. So you want to rule that out also. But I wouldn't say that headaches are a common occurrence among all the people that I treat anyway.
Yeah, and I would say quickly, make sure they're asking any advice or do ERP. I mean, what I would say is, if you're noticing yourself then waking up each day and kind of checking for that headache, am I going to get a headache? That's probably almost causing the headache. So obviously with that, you wouldn't want to like compulsively check, compulsively worry. I can't do anything today because I'm getting headaches. So make sure, not to jump into that. The next question I'll take from Eduardo Fernandez at 12:34. It says, how can I take away thoughts that are repetitive and that harass me? And it basically, the content is hurting and insulting the ones they love the most. So if somebody's dealing with intrusive thoughts around like insulting and emotionally hurting the ones they love, what's the best way to kind of tackle or handle that in treatment? I'll let you take it, Fred.
Oh, okay. Well, first of all, the thing that I tell all my patients, that you can't simply take away thoughts out of your head. You can't reach in, and pull them out or push them out or anything else like that. Thoughts are not directly controllable by us. And in fact, we have a saying that we say, if you want to think about it less, think about it more. because the idea is obsessive thoughts. You can't just shut them down or say, well, I'm not going to think that anymore. And you can't say, don't think about such and such, because as soon as you tell yourself not to think about something, you're already thinking about what you're not supposed to think about. So it's too late, basically. It's what we call a paradox. It's where you bring about the opposite of what you want. So trying not to think the thought will make you think about it more. What the real goal in treatment is to be able to coexist with these thoughts, to build up your ability to tolerate them, to be able to say, okay, I can get the thought, but I don't have to do anything about it. I can just let it be there. I can even agree with it and go about my business and not take it any further. And as a result of good treatment for these things, you can get to the point where I had a patient a couple of weeks ago who said to me, I don't really care about these thoughts anymore. He said, yeah, I still get them, but they don't mean anything to me. And if they happen, I just let them happen, and I, just get on with my day. So that's really the goal. So get rid of the idea of taking away thoughts. You can't, like I said, pull them out of your head, but you can learn to build your tolerance to them, and you can coexist with them to the point where they have no more impact on you.
Really well said. Liz, I'm going to toss the next one to you at 1204 from Row Tom. It says, how do I cure my pedophilia OCD? How do I tackle false memories regarding sexually molesting children?
Yeah, this is a tough one. And, I think it's important to recognize that I think a lot of times we struggle more with, like, what does it look like for kind of these, more difficult sexual intrusive thoughts. But what we know is that ERP really looks the same across the board. So as Dr. Penzel was just saying, really about not trying to think less, because the more we suppress, the louder it gets, right? It's actually about, like, acknowledging thoughts to be there so that they don't become so scary and we can move on. And so we're going to do slow systematic ERP, where we're going to slowly be doing exposures that are values based. This is really important. I think there's been a lot of controversy in the field around, well, what does ERP look like for sexual intrusive thoughts? Or, some of the stuff, like, why would I want to? Exposure should be something I'm willing to do with you. It should be something that aligns with your values, right? So for my pedophilia OCD, some of my greatest exposures were babysitting my nieces and nephews, spending time with them, changing their diaper, right? Doing these things that my OCD wanted me to totally avoid, but I needed to do them while also making sure I wasn't ritualizing, right? So we want to remove the rituals, and we want to do values-based activities. Never do something that you wouldn't be comfortable doing that goes against your values or that isn't appropriate.
Well said. I'll take the next one. It's from Kylie Nash at 1222. How do I deal with the thought that if I get treatment for BDD, I'm just lying to myself, or that everybody around me is lying to me? I mean, I would say that was probably the number one thing I get with my clients that have body dysmorphic disorder, this idea that everybody's lying to them. Everybody's just really polite and telling them that they don't look abnormal. So I'd say to Kylie, that's a big common, fear, is that I really do have something wrong with my face, and the therapist is lying, and my family's lying, and my friends are lying. Always remember, if you go to a trained clinician, one of the things that we do in the first sessions is make sure that you fit diagnostic criteria. And I've had plenty of clients come in thinking they have body dysmorphic disorder when they really just have some body image concerns, or they're not completely happy with their body weight, etc. And I'm not going to give them a diagnosis of something they don't fit. So I know it's a little bit of reassurance when you first go to a provider, but they're not going to treat someone that says they have BDD just because they think it, when there's really something else going on. So find a clinician trained that you can trust. And then once you get that diagnosis, trust it and lean into the treatment versus always questioning if you deserve to be in treatment or not. Fred, I'm going to throw the next question to you. It's from Badhan at 12. I always have to say Amanda's time, 12:59 your time. It's a two-part question. It says, can sexual orientation change over time? I mean, a person who normally is straight, can they fall for someone of the same sex? It sounds like they were triggered by a movie that had a plot like this, and they're a straight person fearing that they might fall in love with someone of the same sex. So with sexual orientation OCD, we hear that sometimes.
Yeah, well, this is actually an extremely common form of OCD. In fact, I wrote articles about this many years ago, and it was probably about the first articles that had been written on it. And at first, some people didn't believe that it was actually a type of OCD, but in fact, it is. When people start asking, can your sexual orientation change, it automatically sounds to me like the person's kind of asking for reassurance in a way that, how do I know? How do I know? What if? And what we're dealing with here is what in the 19th century, they used to call it the doubting disease, basically. And that's one of the central features of OCD is doubt. And OCD can make you doubt literally anything about yourself, even your sexual orientation and the most basic things. So usually when people ask me questions about that, I try not to answer them, because if I give somebody an answer, the answer might last for a little while, but then OCD will just kind of like brush it aside, because it doesn't matter what kind of reassurance you get, OCD will overcome it, and it will not allow you to hold on to that. It's like I tell people, it's like your brain's made out of Teflon, and the information just sort of slips off and slides away. You can't hold on to it, basically. So rather than answer that question, I would say that if a person's really tortured by thoughts that something's the matter with their sexual orientation, it could be I'm actually homosexual, or the thought might even be I don't know what my sexual orientation is. That's another variety of this. People, it's not definite. For instance, I just don't know what I am, or a bisexual, or how do I know, what if, etc. They're constantly checking and looking for evidence and things. And of course, these are all compulsions. Anything you do to try to get rid of the anxiety caused by the thought is a compulsion, basically. So it's not going to work. So again, when you have these kind of concerns, the best thing to do, get a proper diagnosis from a clinician, get into treatment, follow that treatment, do exactly what it tells you to do. And by facing these things and not trying to get answers and learning to coexist with the thought, as I said, this is how you're going to really make a proper recovery, because you won't be able to get it. You could have enough information to fill a library. You could have the whole internet behind you, and it won't answer the question because the information won't compute. It just doesn't work. So instead of trying to get information, we try to get to the point where we see that the questions are really irrelevant and that we shouldn't even be engaging them at all, ultimately, basically. So that's the best I can, which is why I won't answer that question, because I would probably not be doing you a favor if I did that.
Liz, I'm going to throw the next one to you. Similarly, 1206 from Moonchild on YouTube. It says, I'm struggling with the question, am I a bad person? And it's very hard not to answer that question. What should I do?
So remember, right, this is the tenet of OCD treatment, is that OCD is going to attack the things that mean the most to us, right? Being a good person, being strong in our faith, being a good mom, being a good, even employee, right? Doing what's right or ethical, right? All of these things is where OCD tries to latch on and try to pull us down. And so it's really critical that we actually let the thoughts be loud and choose to not answer them, right? So treatment is all about not suppressing, but also not solving, right? If we try to suppress, I can't think that thought, I don't want it to be there, it's going to be louder. Or if we try to solve it, let me understand, let me make sure I'm not a bad person, it's actually not really solvable. So we get totally stuck, right? And oftentimes we'll say things like, I wish I wouldn't have even tried to figure this out. I feel worse now than I did before. And so it's really the way we address it is choosing not to answer it and still living by our life and by our values and leaving it open. But that doesn't mean suppressing it. This is really important, you guys. One of the things that fires me up is that I see a lot of advocates talk a lot about, okay, you guys, you can have thoughts, you can feel uncomfortable and still just push through and do your values-based activities. While that's important, I'm afraid that sometimes we're sending the message that actually is more of a suppression model of when those thoughts come up, just suppress them and push through, white knuckle. And those thoughts are going to keep bothering you. They're going to keep being there. And that is actually a miserable way of having to do exposures. None of us want exposures to be this miserable, daunting, continuously negative feeling or experience. They should actually feel empowering and liberating when we do them, because they should give us freedom. They should increase our insight. It shouldn't feel like we have to just choose to live by our values while really struggling. Instead, we should be able to approach the trigger so that we can live by our values with freedom, and the trigger not being there trying to pull us away from our values continuously.
Well said. I'll take the next one. It's from Halloween Dad 05 on YouTube. It says, what's the best medicine or approach for contamination OCD? So what I always like to tell people is we do know that there's a first line treatment for this. So with medication, I always advise to see a psychiatrist. There's a really good article on the IOCDF's website about medications from Dr. Janicki. And The reason you want to see a psychiatrist that specializes with working with OCD is typically they found in research that the amount of medication, the milligram dosage, has to be higher for individuals with OCD. So frontline medications for OCD is an SSRI, a selective serotonin reuptake inhibitor. The common ones we hear are things like Luvox and Prozac and Lexapro. There isn't a right or wrong medication. There's a lot of factors, and that's why you really want to see a prescriber that can work one-on-one with you. Now, are there other medications that are supplementary or medications they'll go to if an SRI doesn't work? Absolutely, but the reason we call it frontline is you want to start there because it's shown to be the most effective. As for contamination OCD, exposure with response prevention is the gold standard frontline treatment for OCD as well. And that's where you'd want to start. Now, clinicians can be trained in things like acceptance and commitment therapy. They can be trained in mindfulness-based CBT and other adjuncts, but the core is always going to be ERP, and that's what we find to be most effective. So you want to start with a clinician and a psychiatrist that is working with those modalities, and make sure that they work as a team. So the providers are talking to each other.
Yeah. Thanks for answering that, Chris. And I'm going to hop in because I know we're just at the 5-minute mark. I know you want to ask more questions, and there's so many there, but we're not going to be able to get to them today. So what I will tell y'all is that we will bank these. Chris and I will continue to ask them. I know today was slated for what felt like a Ask the Experts, but it was actually Lunch and Learn because of the transition. So we apologize. We didn't do just Q&A, but we will definitely do that. And I just want to say a special thanks. Thank you so much, Fred, for not just today and what you've shared around insurance and how to navigate it, but for what you've done in this field, and for you and your wife's dedication to OCD, and to those of us that have been struggling or have struggled in the past, because your work, your impact is very profound. And so I just want to say a special thank you. I know that everybody is grateful for you.
Thank you for having me. It's always a privilege to be able to make some kind of contribution.
Do you have any final advice? People out there, Fred, that are trying to get treatment, navigating insurance or not, just like a final thought that you have to kind of wrap up the topic before we go that you think would be helpful, like a bullet point people should definitely
well, as I said earlier, as with anything, always be a good consumer, and not just in dealing with insurance companies, but just in getting treatment in general. Inform yourself, educate yourself, find out what you're dealing with, and get that relevant information, and or get help if you find yourself struggling with it. The other thing is that OCD is very treatable. You don't have to suffer in silence. You don't have to go without treatment. You don't have to feel less than other people, or feel that you have to be stigmatized or anything else like that. I think as a former director of the foundation used to introduce herself, she would say, "I'm a person who also happens to have OCD." And I think that's a good way to think of yourself.
Totally agree. Just remember, you have to be your biggest advocate, and don't let anyone else be that for you, especially the insurance companies. Chris, we'll let you end it off today.
Yeah, I mean, I think the thing I want to end it off with is Dave Costa's comment at 12:33. It said, "Thank you, Dr. Penzel. Your 2000 book, A Complete Guide to Getting Well and Staying Well, was my first OCD book. Very enlightening and helpful. I'm grateful for your work and continued support to the community. Much kindness." I run a support group weekly, and I was showing them different clips from the virtual conference, and people really, really resonated well with your conference about like your presentation about like getting into kind of like the head frame and changing. You were talking a lot about like life is suffering and talking about like being in that mind state and stuff. And a lot of my clients found it really helpful. So as always, thank you for lending your expertise. You're definitely somebody we all look up to in the field. You were really helpful today. And then as always, what you all saw me doing is I clipped all of the questions that we didn't get to today. There was about 5 more that we didn't get to. So what we'll do is next stream, we'll prioritize those 5. So we're here every Wednesday, except the second Wednesday of the month. Liz and I are here from at 9 a.m. my time, 12 Eastern time. And like I said, our next live stream where it's Ask the Experts, where we're answering questions. We'll get to those 5 first. If we didn't get to your questions, please come back. We're here every Wednesday except the second Wednesday of the month. But thank you everyone for coming out and supporting this important topic of how to navigate treatment. Any final thoughts, Liz?
No.
Thanks, everyone.